On behalf of the Botswana NTD surveillance team, good morning. For disclosure, I have no conflicts of interest to declare. In 2018, Botswana was poised to provide data on dolutegravir. The country implemented DTG-based ART as first-line therapy for all adults, including pregnant women, in May of 2016. The PAMO study findings raised concern about a possible neural tube defect association. More data was needed to understand the possible association. Botswana was uniquely positioned to provide the needed data on the safety of DTG, as it had sufficient number of women with DTG exposure at conception. To expand birth surveillance in Botswana, the Ministry of Health and Wellness, MOHW, initiated the NTD surveillance study. This study was conducted in collaboration with the U.S. Centers for Disease Control and Prevention, CDC Atlanta, and Botswana offices, as well as the Botswana University of Maryland School of Health Initiative, BUMI. Study funding support came from PEPFAR, and the study design was informed by the PAMO study methods. After May of 2018, coverage of birth outcomes in Botswana was increased. PAMO added another 10 sites together the original and the expansion sites covered 72% of births. The MOHW NTD surveillance study, which was conducted at 22 health facilities with the highest delivery volume outside of PAMO study sites, added coverage for 19% of Botswana births. So together, PAMO and MOHW studies provided birth outcome surveillance of more than 90% of births in Botswana. The study used prospective NTD surveillance. Site locations are shown in red on the country map. Prospective surveillance watches for outcomes among a cohort of subjects. In our study, we enrolled mothers who delivered infants, live births and stillbirths greater than 24 weeks gestation at the study sites from October 2018 through March of 2019. The study used an IRB-approved protocol. The next several slides show the surveillance procedures. At the maternity unit, after delivery, the midwife systematically examined the infant. They then completed study cover sheets that asked for specific HIV information and documented the head, neck, and spine examinations, as this was not routinely documented in the standard ANC or delivery obstetric record. Designated facility study surveillance assistants abstracted data from the cover sheet and obstetric record and entered it into the REDCap electronic database via a tablet. If an infant with suspected NTD was delivered, in addition to the standard documentation done for all deliveries, maternal consent was requested to photograph the infant, and extra information was abstracted from the mother's obstetrical record. Suspected NTDs were reviewed and classified by the clinical geneticist at CDC Atlanta. The geneticist was blinded to ART exposure and other clinical history. The team of study staff regularly visited sites to thoroughly review documents and assure data quality. The study exposure of interest was ART at conception. HIV-positive mothers were categorized as ART exposed, not exposed, or unknown. The ART regimen categories were DTG-based, non-DTG-based, and efavirenz-based, as shown on the right. The mother's last menstrual period was used to determine the periconception timeframe. The outcome of interest was NTD classification. The 4 NTD categories were: 1, not an NTD; 2, possible NTD, which we applied when the description or drawing was insufficient to determine NTD status. Probable and confirmed NTD classifications 3 and 4 were made when detailed documentation of the defect was provided, but a confirmed NTD had photos and surgical records available. Again, let me also remind you that this data is embargoed and it will be presented on Monday. The embargo will lift on Monday, so kindly refrain from taking any photos. So between October 2018 and March 2019, our surveillance system captured 3,076 pregnancies who delivered at the 22 sites. 742 mothers, 24%, were HIV positive. 2,328 mothers were HIV negative, and 6 mothers had unknown HIV status. Of the 742 HIV positive mothers, 544, about 3/4, were on ART at conception. Of the 544 HIV positive mothers who were on ART at conception, 152, or about 28%, were on a DTG-based ART regimen at conception. 381 mothers were on a non-DTG regimen, and 11 were on unknown regimen at conception. Of those on non-DTG-based regimen at conception, 261 were on efavirenz-based regimen. The colored boxes on the slide represent the different exposure groups that were analyzed. The surveillance system identified 6 suspected neural tube defects within the participating facilities. These cases were reviewed by the CDC clinical geneticists, and the determinations were as follows. 2 were not NTDs. Both cases were sacral dimples. 1 possible NTD, which was an unspecified lesion on the side of the head. 2 probable NTDs, 1 spina bifida alone and 1 spina bifida with frontal encephalocele, and 1 confirmed NTD, which was a spina bifida. The 2 probable and 1 confirmed NTD cases were the outcomes that were included in the analysis. Of the 3 NTDs included in the final analysis, 1 occurred among the 152 DTG-exposed HIV-positive mothers. The other 2 NTDs occurred among the 2,328 HIV-negative mothers. The NTD prevalence among the DTG-exposed HIV-positive mothers was 0.66%, with 95% confidence intervals between 0.02% to 3.69%. NTD prevalence among the HIV-negative mothers was 0.09%, with 95% confidence intervals between 0.01% to 0.31%. As the dolutegravir-based ART regimen, TLD, is rolled out, countries will be interested in how best to monitor birth outcomes. They will consider 2 approaches, surveillance and pharmacovigilance. To choose well, decision makers will need to understand and consider the differences between these 2 approaches. Surveillance is a reliable method to establish the DTG-NTD association. Its advantages include data collection methodology that is continuous and systematic. The approach provides a denominator to estimate the magnitude and scope of birth defects, and the starting point is the outcome, which is the delivery or the NTD. Surveillance, however, can be challenging because it requires a large sample size to detect the rare outcomes of birth defects. It is complex and resource-intensive. Pharmacovigilance, on the other hand, is a common post-marketing approach to capture adverse drug effects. Pharmacovigilance provides no comparison group, meaning that no information would be collected on HIV-negative women. It is not designed to collect data from maternity wards because its starting point is the exposure, the DTG at conception, and not the NTD outcome. In conclusion, we found a small increased NTD prevalence among infants born to HIV-positive mothers on DTG at conception compared to infants born to HIV-negative mothers. The study was conducted for only 6 months, resulting in a small number of deliveries. Consequently, our NTD prevalence estimates have wide confidence intervals. However, our data suggests that NTD risk with DTG exposure at conception remains less than 1%. This is consistent with the Tsepamo study findings reported in 2018. I would like to acknowledge my colleagues from Ministry of Health and Wellness, CDC Botswana in Atlanta, and Bumi. Thank you.